Hello and welcome to Let's Talk Transplant with University of Missouri Healthcare Transplant Team. My name is Debbie Ulm and I am the ESRD Program Manager for QSource ESRD Network 12. On behalf of the staff of Networks 10 and 12, we want to thank you for being here with us today. As you probably already know, Network 10 serves the state of Illinois and Network 12 serves the states of Missouri, Kansas, Iowa, and Nebraska. We wanted to invite you all here because of the potential to multi-list or dual list at this or other centers in your area. A couple of housekeeping notes to start. We are recording today's session so that we can send it out after for those who are not able to attend our live session. All lines are muted, so if you have a question or comment, please write it in the chat pane and we will field those questions during our question and answer session. You will notice in the handout section, there are 3 handouts. One is a contraindications form that will be discussed during the presentation. One is the referral form that you can use to refer a patient, and the other is the My Transplant workbook that I'll talk about in a few minutes. So hopefully you all are familiar with the interaction pane. You have a little probably orange colored arrow. If you click on that, you can get to those questions and chat panes. So feel free to ask questions on there during the presentation and we will get to those after. Here's a quick glance of the agenda for today. We'll briefly touch on the transplant quality improvement activity goals for the networks, and then we'll turn it over to the University of Missouri for their presentation that will cover the following topics: the referral process, transplant evaluation, waitlist management, dual listing, selection criteria, living donation, and barriers to transplant. We'll follow that with a question and answer session, and then you will be able to fill out a short survey following the presentation. We would really appreciate your feedback so that we can make improvements in the future. So as far as the network transplant quality improvement activity, it's a network-wide activity, and our goal is to increase patients receiving a transplant through early promotion, implementation of interventions, and shared decision-making with all patients. The time that we'll be measuring our success is from January of this year through September of this year. Again, the goal is network-wide, and we will focus on dual or multi-listing with different organ procurement organization regions and focusing on reaching those in rural communities. These are the steps to transplantation, which is the partnership between the dialysis center, patients, and the transplant center. So these are just some general guidelines. So facility screens patient for interest in kidney transplant. If the patient's already listed, then continue with multi-listing education. Facility works with the nephrologist to refer patients to transplant center and assist with transplant center appointments, dates, and follow-up. The facility or nephrologist discuss with patients the transplant workup process and educates on how to self-advocate for living donation and KDPI kidneys. Then the facility continues to work with the evaluated patients on process updates, procedures, and next appointment dates. Then hopefully the patient is placed on the kidney transplant waiting list. And then during that time, the facility is to maintain an open relationship with transplant centers to watch for active or inactive patient status. And then finally, the facility continues working with both patients and transplant center to meet the needs of the patient that is transplanted. We wanted to let you know about a new resource that's now available thanks to the hard work of the Missouri Kidney Collaborative, led by the Missouri Kidney Program team. Several different organizations work together, including Network 12, to develop this resource. It's an easy to understand step-by-step guide for patients and those who support them through the transplant journey. It's meant to be a fillable PDF, but can also be printed to take with you to appointments. Please visit mokp.org/transplant to find and download the workbook. It has also been included in the handout section of the webinar. Before we get started, Shane Perry is going to help us with a few polling questions.
Thank you so much, Debbie. On your screen, everyone should have, you should see the first polling question that we have. We have about 4 or so polling questions we're going to ask today. All we ask is that you go to your computer, make a selection, and submit that option. The first question is, are you a nurse, social worker, administrator, physician, or other? This is a select one. I'll keep this polling question open for 3 more seconds because we're almost up to 80% of the folks who are on the line having voted. So that's 3, 2, and 1. I'll close down the polling question, and I just want to thank everybody for making your selection. The majority of individuals on the line are social workers, followed by nurses, and then administrators. So I do appreciate you for responding. The next polling question should be on your screen right now. This is a select one as well. And the question is, how many people are watching with you? You want to get a gauge for how many folks are in the room with you. So is it just you? Or is it, 2 of you? Are there 3 or 4, 5 or more? I will just keep this polling question open for 2 seconds because we're already at 85% voted. So it's 1, and it's a 2, and it's a done. So I'll close that polling question. Thank you so much. The majority of you are just viewing it by yourself, and that's A-OK. The next polling question is on your screen. This is a select all that applies. You get to pick more than one option. Do you currently have patients on the transplant waitlist? I'll give you the chance to submit your vote. I'll keep this polling question open for 5 seconds. And that is 5, 4, 3, 2, and 1. Excellent response rate. Again, thank you so much. 80% of the folks who are on the line responded to that question. And let me take you to the last question we're going to ask in our online poll. What are you most interested to hear about today? So you have 4 options. I'll keep this polling question open for 7 seconds because there's a little bit more words to read. That's 7, 6, 5, 4, 3, 2, and 1. Thank you so much for voting. Primarily, folks are interested in how to better prepare patients for transplant workup, followed by communications between the dialysis and transplant facilities, multi-listing for patients, and a few folks had even answered criteria requirements for University of Missouri. Greatly appreciate you having shared that with us. I'll turn the presentation back over to Debbie.
Thank you, Shane. I appreciate that and appreciate you all participating with us. So now I want to introduce Dr. Preethi Urim from the University of Missouri Healthcare Transplant Center. Dr. Urim is an associate professor of medicine in the Division of Nephrology at the University of Missouri Columbia, where she practices general and transplant nephrology and serves as a primary transplant physician for the transplant program. She is also the medical director of DCI's home dialysis and transitional care units in Columbia, Missouri. She's actively engaged in the ESRD Network 12 activities and advocacy and currently serves as the chair of the ESRD Network 12's Medical Advisory Board and Missouri Kidney Programs Advisory Council. Welcome, Dr. Urim, and I will turn over the presentation to you and your team.
Thank you so much, Debbie. I'm really excited actually to be doing this today and collaborating with the network. And our team has a lot of information to share. So we really hope this would be helpful for the people out there that are getting patients ready for transplant and referring them to transplant centers. Next slide, please. So this is a picture of our transplant team, the team that makes our program run. And we really pride on the camaraderie we have between our staff, our physicians, nurses, the coordinators, and we really work as a great team. And frequently patients actually comment on how well they like the relationship they establish between the transplant team and themselves. Next slide, please. We can move to the next slide. Yeah. A little bit about the program history. Our first kidney transplant at the University of Missouri was performed in February of 1972. And we are now approaching about 1,200 transplants. Yeah, just keep moving on the slide. We perform both adult and pediatric transplants, approximately about 20 to 25 kidney transplants per year. So we are a relatively small program compared to some of the bigger programs in our vicinity in the metro areas. But as I previously said, we really take pride in the relationships we establish. And, a lot of times patients comment that, they really like the one-on-one attention they receive from our program compared to some of those bigger programs. So we have a very stable and engaged physician, nursing, and administrative leadership that is very motivated to make the program successful. Our staff and physicians are also actively participating in OPT and as well as the organ procurement organization activities with committee membership. And we also have a very highly performing organ donor hospital. So our hospital has actually been recognized for being one of the higher achieving organ donor hospitals recently. In terms of the location, we are located in Columbia, Missouri, and the program serves usually the rural mid-Missouri area. We have a metro population of 180,000. We are about 120 miles from urban centers in St. Louis and Kansas City. Our state population is 6 million. We do have referral bases mainly in rural mid-Missouri, as previously mentioned. And we draw patients from all the 115 counties. But in the last 3 years, we have drawn patients from 48 counties. Next slide. So in terms of the staffing of the program, we do have 3 full-time credentialed transplant surgeons, of which there are 2 urologists and 1 pediatric surgeon. So I think this is another advantage in our program. We have urologists that are actually performing renal transplant surgery. So they have a lot of insight into any anatomical issues that may come up with the urinary tract. And there are very few programs that do have the urologist performing transplant surgery. So I think this is a big advantage for our program. We also have a pediatric surgeon that performs pediatric surgeries, as well as a pediatric urologist that is closely working with our team. In terms of transplant physicians, we have 2 primary transplant nephrologists, including myself. We also have 2 medicine and pediatric trained nephrologists that are involved in the care of the pediatric patients. We have 3 nurse coordinators that are helping with evaluation of the patients before the transplant, living donation, as well as taking care of patients after the transplant. In addition, we have a social worker, a financial coordinator, the transplant manager, and administrative support to make everything run smooth. So that's all I have, and I will turn it over to Chelsea, our transplant coordinator.
Okay, I think Cheyenne was going to take these slides.
Yes, I am. I'm Cheyenne Warren. I am the office support specialist, and I'm going to go over the referral process. So the referral process is actually really easy. Anyone can refer a patient. I get most of my calls from patients normally, but social workers, nephrologists, and dialysis units can also reach out to me. The main way I get the referral information is we have a referral sheet. It's 2-sided, just the basic information we need, and I usually send that to the patient's dialysis unit if they're on dialysis. If not, I will then send it to their nephrologist. Once the dialysis center or nephrologist receive the referral sheet, I can send it either through email or fax, and they send the information filled out back to us with insurance cards preferably. We then go through insurance verification. That would be done by our financial coordinator, Stephanie Stapp. Once she receives the referrals, she then types an introduction letter and information is sent to the patient. And then she will then pass their information back to me when she decides if they are a candidate for our program. I then gather information from the referrals to then reach out to the patients. So then the patients will receive a call from me and I will set them up for their first initial clinic visit with our whole team. Okay, next slides. Chelsea, I'm ready for the note. Thank you. Okay. And then one of the questions is how do we reach out to rural dialysis units? So there's a few different ways. So we do extend our services to rural patients. The main way that we get our information out is our social worker, Sydney, will send out flyers and pamphlets about our program to nephrologists, primary care providers in rural dialysis units, so that patients can then, pick up the pamphlets, pick up the flyers, and be able to gather a little bit of information about us, so then they can then reach out to me to start the referral process. And then we also travel to rural dialysis units just to inform people of our program. And then with the referral sheet as well, I forgot to mention the prior slide, I can also just send those out to dialysis units and nephrologists, just blank referral sheets that you guys can then just have on hand and fill out and fax to us. So it will have our fax number on it. So sometimes you don't even have to call us. You can just fill out that sheet and send it to us to get the process rolling. But that is basically all. The referral process is very easy.
And then after the referral process, once we start evaluating the patient, we have some key steps we follow. So once we receive the referral, as Cheyenne mentioned, we'll get, if the patient is deemed a good candidate, we'll bring them into clinic where they kind of get to meet with our transplant team that consists of our surgeon, Dr. Wakefield, our transplant nephrologist, Dr. Urim, our dietitian, Aseneth, and then our social worker, Sydney. This is kind of a longer clinic appointment, but it's a chance for us to really evaluate the patient, give them a lot of informational handouts and speak with them, and also gives them a chance to ask questions about our program and the process as well. During this appointment, they're made aware of everything, pre-transplant, during, if they would get a transplant, and then the expectations of post-transplant. After we meet with a patient in clinic, we have weekly team meetings where our whole multidisciplinary team meets. And in that meeting, we review, patient concerns, and then also our clinic patients that we evaluated. And so we determine from then if, they are going to be a good candidate in our program. And what we do is we then, go over what testing we want them to come back in for. And that could include, first getting records from outside facilities or some information from the dialysis units if we're concerned about compliance. And then, so this is just a list of some of the required testing that we have patients come in for, which includes, a chest x-ray, a cardiac stress test, an echocardiogram. They definitely have to get some blood work, and we do like to get their blood typing as well. They usually need a CT of their kidneys too, so our transplant surgeon can kind of view if they have, good vessels to work with and are, would be a good, surgical candidate. We also require the patient to provide dental clearance. Usually for the first dental clearance, we like it to come from a dentist. And then, if they come for annual testing, the next year, if they're still on our list, then we will just get an X-ray Panorex. We like documentation of a TB test, preferably within the last year, and then immunization history. And this is really where we work closely with the dialysis units if they are on dialysis, is to request an updated immunization history so that we can add it to our forms. And then when we get this testing, after the patient's completed it, we review the testing to see if it's acceptable for them to be listed on our transplant list. And sometimes we do note abnormalities, such as an abnormal chest x-ray or an abnormal cardiac stress test. So we would then, educate the patient and help set them up to see specialties as, to get clearance through our cardiology department, or if they need pulmonary clearance, we work with the patient as much as we can to help get them that clearance they need in order to be listed. Okay, I'm going to turn it over to Mary Beth now.
Hi, everybody. I am Mary Beth Stevens. I'm the other pre-transplant coordinator along with Chelsea, and I'm also the living donor coordinator. So I'm going to talk a little bit about what happens once they go on the list. So I'm on the list, now what? So we like to say, well, you start waiting. So the average wait time for a deceased donor kidney is usually between 3 to 5 years based on blood type. And it's important to know that, when your patients go on the list, they may have been doing dialysis for a couple of years by the time they get on the list. And when they do go on the list, their wait time is backdated to their dialysis start date. So, if you've had somebody who's been dialyzing for 2 years, they get on the list, they've already essentially got 2 years of wait time. So that's important to know. Other things that you should be aware of is that a lot of times the patients are confused about their wait list status. And so once you're on the wait list, you're on the wait list either active, which means you can get kidney offers, or inactive, which means you can't get kidney offers. And the difference between those two things is with the inactive, you might be inactive because you're too sick, you're going to go on a vacation outside the country and you don't want to be active, so you call us up and tell us that. But inactive doesn't mean you're off the list. And lots of times the patients are confused about that. They may say, I'm off the list, but what's really going on is that they're inactive. But they stay on the list. The important thing is that they stay on the list and they're accumulating time. Also, for every year that they're on the wait list, they need to come back and see us to repeat their testing. They're a little bit confused about that too. So having you guys in the dialysis units know how this process works is very helpful. They'll have to come back and repeat their testing and see our transplant doctor, Dr. Yerm or Dr. Wakefield, to make sure that they're still healthy enough for transplant, because this could be a process that goes on for years. One of the things that we do look at prior to listing and as they continue to wait on the list is whether they are doing what they are supposed to be doing. And in our eyes, that is that they are taking their medications as prescribed and they're following their dialysis prescription. So like if they're signing off early, they're not coming and not rescheduling that session, we always want to know about that. So that's why we like to have good relationships with the dialysis centers. If they're not taking their medications, like their binders and things like that, we use this to gauge whether or not they are going to do what they want, that we need them to do after transplant. If they're not taking their meds before, they are probably not going to be very good at taking their meds after. And if they're not taking their meds, they're going to lose their kidney. So that's always an important factor. Another thing that you will be doing once they go on the list and they're waiting is you'll be sending in a monthly blood sample. So you'll probably get an order faxed to you from the dialysis center for something called an RAS, or a recipient antibody screen. And that's where you have like those kits, or the patient's bringing in a kit to the dialysis center that the vial has to be filled with blood and it's sent out by FedEx. In our case, it's Midwest Transplant Network. What we do with that monthly blood sample is that we look at their antibody levels, and that would be antibodies to other people's tissue. Some of the patients have that because they've had previous transplants, or sometimes you have antibodies because you had a blood transfusion, which is kind of why we don't particularly like our patients to be transfused, or pregnancy sometimes does that. Also, another reason why that blood sample would be important is that we use that sample, that monthly sample, to cross-match to kidneys that become available. So when that sample doesn't come in and we get kidney offers, and we have to decide whether we're going to take that offer or not based on how old the sample is. So it's very important for that to go out every month. Okay, so let's talk a little bit about dual listing at other transplant centers. So I'm going to tell you what the current system is. The current system, when we talk about dual listing at transplant centers, is that you typically, donor kidneys are offered out in their donor service area right now, or their organ procurement network. This is a geographical area. And I'm going to guess that maybe the United States has maybe 50 to 60 of these areas, donor service areas. Ours is Midwest Transplant Network, and this goes from basically Columbia, Missouri, all the way through Kansas. That's what our donor service area is. If you go east to St. Louis, that's Mid-America Transplant. That's that organ procurement network here. Typically, deceased donor kidneys are offered out in their networks first before they go outside the network. Now, there's a million exceptions to that rule, but that is typically how that is done now. So UNOS, United Network of Organ Sharing, has decided that this is going to change. But in the current system, if you were to dual list, you would list in our organ procurement network, and then you would go to the one next, like say over to St. Louis, and list there. Or you could go north and list in Iowa City, because that's a different organ procurement network. So you can list in as many networks as you want to for kidney, as long as you can get there in time for a kidney. And most of the time you've got time to get there, because offers can go on for more than a day or two, and there's time that organs have to be allocated. So what they are going to change it to, and I am not entirely certain when this is going to happen. The last I heard was December. I may have to ask Dr. Yerm about that, but the donor service area is going to change to and it's actually 250-mile radius. I don't believe it's 250-mile radius from the donor hospital. So offers that come for kidney recipients will come from, or that listed at transplant hospitals within a 250 nautical mile of the donor hospital. So wherever the donor hospital is in relation to your transplant center, those kidneys are going to be offered out within the 250-mile radius from the donor center. So that changes things up a little bit, in that dual listing is going to involve listing at basically any transplant center that you want to list at. Currently, if you list at our center in Midwest Transplant Network, you don't list at another center, because all the offers are coming to the centers within the same network. So if you wanted to list at KU and us, there's no point in doing that, because we get the same offers. You just list at one center. This is going to change when the 250-mile radius from the donor hospital center happens. And then it's not going to matter. You can list at any hospital you want, or as many as you can, in order to get a kidney. I don't know if that was clear as mud, but that's kind of how I understand it. And like I said, I'm not entirely certain when that's going to go into effect. I heard it was December. So Dr. Yerm, do you have anything that you want to say about that if you're still on the call?
Yeah, I think, when I was at a meeting recently, they were talking about whether this is going to be helpful in multi-listing, but I think you get proximity points. So if you're closer, if you're listed at a center and the donor is coming out of that, you would get extra points for being listed at a center. So I guess in that sense, you will get an extra advantage in multi-listing, even though, they all may be in the 250-mile radius. If you're listed at multiple hospitals, and if you are listed at a good performing, like a highly performing donor hospital, then you may be at an advantage. And I believe this was going to go into effect this year, later this year, but I don't think it's been in effect yet.
Okay, thank you. So that is our discussion on dual listing. The other things that we as a transplant center like is to have the most recent phone numbers and insurance information for the patient. Lots of times they change your insurance and we're not aware of it, and then they may get called in for a transplant, and that's an issue. And also contacting patients. So lots of times they have track phones, they change their phone number. So that's kind of an ongoing issue too that I think that the dialysis centers could be very helpful with. And then the last thing for the patients is they should look for a living donor. So Chelsea, next slide, please. So I'm also the living donor coordinator. And generally what I tell patients is that they should let their friends and family or their church family know that they're looking for a donor. If they have people that are interested, the potential donor has to call our office for information. The patient can't call and say, I've got these people lined up, here's their phone numbers, give them a call. The donors have to do the calling because we want to make sure that they're not being unduly influenced to give a kidney when perhaps they're not that interested. So them calling shows us their interest in donation. So you can hand out your contact information or our contact information to any potential living donors. And what I always tell them is, because a lot of times the patients are like, I just hate to ask, but all I tell them is, let them know that calling us is information. It is not an obligation to proceed with donation. And that's what the original call is like. We give them information. Tell them to call us back if they continue to be interested so that they can make an informed decision. That's why we do that. So if they have a donor that comes in for testing and it turns out that they can't donate directly to them, either because their antibody levels are high or there was a positive cross match, meaning they would reject the kidney, they can go into something called a kidney paired exchange. And that's basically, there's many ways to donate where you swap with another incompatible couple, or you can have 3 couples that go into a swap or a chain. So there's a lot of ways to donate regarding paired exchange. So that is also an option. And then also we just recently got into a research study with Johns Hopkins so that our listed patients have the opportunity to use something called the donor app, which is using social media to find a donor. And this has been, increasingly obvious within the last few years that a lot of people are using social media like Facebook and Twitter to find themselves living donors online. And you'd be surprised, a lot of people will call not knowing who their recipient is, but happen to see their page online. So we decided to participate in this research study, and it's conducted in coordination with Johns Hopkins University. And we just got into it, and COVID-19 kind of messed up our flow, but we're hoping to get more people signed up. So next slide, please. And this is, just a picture of the donor app, smartphone app to help people find living donors. You'd never think there'd be an app for that, but there is. So this is something that can also be mentioned to patients. Anytime we think that we have a way to increase living donation and help our patients find a donor, we're certainly going to take that route. And I think that is it for my presentation. Unless I'm talking about barriers.
Oh, nope, I can take that.
Okay.
And this is Chelsea. I forgot to introduce myself earlier. I'm one of the pre-transplant nurse coordinators. So a few of the main barriers to transplant include our contraindications, which is listed in the handout that goes through all of our contraindications. But the main ones that we notice are, if a patient's referred to us and, we do get some records or they list their medical history, and we note that they have, cardiovascular disease or artery disease, peripheral vascular disease, liver disease is a big one. And if they've had a recent cancer diagnosis or treatment, we do, there are guidelines we go by. So there usually is some wait time for patients who have had a history of cancer. We also look on the referral form specifically at their height and weight, and we look for their BMI. So when filling out that referral form, it's very important to put the patient's height and weight because we do look at the BMI. Usually if they are over a BMI of 40, we do not accept. They would get, a not a candidate letter at this time, and then we give the patient goals to work on and give them a reason. If they did drop below BMI 40, we can bring them in for evaluation if they didn't have any other contraindicating medical diagnosis. Another contraindication is active substance abuse, whether it be alcohol, drugs, or tobacco. If they have an uncontrolled psychiatric illness, and also if we get some records from the dialysis unit that they are skipping, shortening their dialysis sessions, not taking medications as prescribed, that's kind of a red flag to us that they probably will have some compliance issues. And also the financial aspect, if they have a lack of a plan to pay for surgery or medications, we like to be aware of that too, so that we can try to work with the patient to try to resolve as many of these issues. These are just some of the patient compliance things that they can do to help us, in the process. So we ask that each patient keeps healthy, through physical activity, avoiding people with, if they know they're sick or ill, and then always washing the hands often to help prevent illness. Like I said, if they are obese, we do tell them that they need to lose weight, so we encourage weight loss. If they are a smoker, we encourage to stop smoking or to show that they're weaning down and can do that. That's good. And then like Mary Beth said, we always encourage finding a healthy living donor. And also if they do home dialysis PD, that kind of shows us that they have some, autonomy and can self-manage, and that may help them stay healthier as well. And then communication with the transplant program, specifically with dialysis units. Kind of back to what Mary Beth said, we really like to know if the patient has had a change in insurance, phone number change in address, because we are in frequent contact with them. And also if we were trying to bring them in for a transplant, but we couldn't get a hold of them, that poses an issue. We do keep in contact with dialysis units pretty frequently, especially as coordinators, to get updated information, to check on their compliance, and also to make sure they're getting their monthly samples if they are listed with us. And we also like to know if the patient has had a recent hospitalization. In case they are active with us, then they need to be made inactive until they're fully recovered. Okay, I'm going to hand it over to Kathy.
Oh, thank you, Chelsea. My name is Kathy Ashbow. I am the post-transplant coordinator. So I work with the patients from the time of transplant while they're in the hospital, and then I follow them up in clinic along with our transplant physicians, social workers, dietitian, and pharmacist. So I wanted to address a couple of questions that might be commonly asked by patients, and I know that one of the areas our participants were interested in is how to prepare patients for transplant. And so we have to figure, some of the questions that I receive is patients are surprised that the transplanted kidney does not go in the same place as their native kidney, or according to this diagram, it's called the diseased kidney. So patients will end up with 3 kidneys after a kidney transplant. The transplanted kidney goes in the right or left iliac fossa. And that's a good location, especially if patients need to come in for a biopsy. That kidney is easy for us to access if they have to put a needle in to withdraw some cells to determine if there's a problem with rejection. So according to the diagram, you can see the anastomosis of the vein and artery for the transplanted kidney goes into the aortic artery and the aortic vein. The blood for the blood supply to the transplanted kidney, and then the ureter is sutured into the bladder for urine flow. Next slide, please. So then I wanted to talk a little bit about the recovery process, because in order for patients to determine if they're interested in getting a transplant, they have to know what they're getting into. And I think for patients, transplant can give them an increased quality of life. Certainly the dietary restrictions are less. There are some dietary restrictions, but they're different. We tell patients to increase their fluid intake and then also to increase their phosphorus, which is just the opposite of what they're used to. Also, patients are interested in transplant that may allow them to travel if they're restricted as far as going to an in-center dialysis unit. So we have restrictions typically for 6 to 8 weeks. Patients are usually in the hospital for a week. We ask them for no lifting more than 5 pounds for the first 4 weeks. They may be able to go back to work in 12 weeks. Sometimes we'll look at patient by patient. They might be able to go back to work in as little as 8 weeks, depending on if they have a desk job or if they have any physical activity or lifting restrictions. Also, we have to tell patients, depending on their job, if they have exposure to crowds or exposure to lots of people in an office, we do want to limit their exposure for at least the first 12 weeks after transplant. They have weekly appointments. Sometimes that's an issue for our patients if they live very far away, but we do want them to come to clinic weekly. Certainly during this pandemic, we have had quite a few telehealth visits, and that has helped some of our patients not have to travel as much. I anticipate telehealth will become more popular, but we are starting to bring our patients back for some in-person visits now. We ask them to have labs done twice a week, one here at the University Hospital and then once at a local hospital. They do have to have their vital signs, their temperature, their blood pressure, their weight, and their urine output. We ask them to record that daily for at least the first 4 weeks. They're on an average of maybe 12 medications. Some are the same, most are different medications after transplant. Medication management is very important. We know that if they don't take their medications, then their kidney will fail. And of course, reporting any adverse events. All medications have side effects with them, so we try to manage those side effects as best we can. And for transplant, we're fortunate that we do have, if some immunosuppressive medicines might not work, we have a few other alternatives that we can try patients on. So we do ask them to tell us if they're having any problems with side effects. I like to tell patients that in order to, the vital signs and all the things, the blood work that we do, we're trying to detect problems early, because if we can detect a rejection or infection early, there's obviously a much better chance that that is reversible. I think that's all I have on the post-transplant. Thank you.
And Sydney, did you have anything that you wanted to add?
This is Sydney. I'm a social worker. I guess just to go over a little bit about the social work side of things, since most of the people listening are social workers. I meet with patients as part of their initial clinic evaluation. I will ask some questions trying to determine if they have social support at home. I like to try and figure out if there might be any barriers to post-transplant compliance. One question we get is about marijuana, and it's not a specific contraindication. We haven't decided as a program that we will not accept patients that smoke marijuana. However, one concern that I have is if a patient is a daily marijuana user and it is a primary coping mechanism for them, that could become problematic post-transplant, because if they spend a significant amount of time in the hospital without access to marijuana, they could become depressed or nauseous and not want to eat, or have a number of things that would make it hard to maintain their transplant. So that is something that I discuss with patients in their pre-transplant appointment. If they are daily marijuana users, they really need to think about how that would affect them to have no access to marijuana in the hospital. Another thing is sometimes we will refer patients to counseling. It's pretty common. because transplant is such a significant event, we like to make sure that patients' coping skills are all shored up before surgery so that they can cope with the big life change and the surgery and be able to be successful. I also follow patients after transplant, helping them to get rides to their appointments. If they're having trouble affording their medications, we have a medication liaison here in the clinic whose entire job is to find all those great coupons or loopholes where they can get the best possible price on their medicine. However, at the end of the day, once all of our coupons and insurance and everything is exhausted, eventually, the patient is going to have a plan for their medication. They are responsible for making sure that their insurance stays active and turning in their paperwork on time. I can help with some of that, but they do need to make sure that they do things in a timely fashion. And another thing that I handle is resources. We have some access to grant funds and things like that, especially for living donors. We don't want living donors to incur a large cost by donating a kidney, so we can apply for money to reimburse them for travel and hotel stays and lost wages, things like that. And the final thing I'll say is Dr. Urim mentioned that we work very well together as a team. We're a smaller program, and we find that a lot of patients who might be intimidated by bigger cities do tend to like us. We're all very good about answering our phones. It's not an automated system or anything like that. You can call our number and get straight to our desk, and we tend to be pretty friendly. And since we don't have such a massive volume of patients, we do tend to get to know our patients very well and do everything we can to help them get listed. If we identify a problem and think there's a chance that some rehab or some additional tests would help, we will work with our patient because we would like to see them transplanted just like they would and we would. And I think that's all that I have.
All right, are you guys ready for some questions?
Yes.
Yes.
All right. And we have one, I believe that Dr. Yera maybe answered it in the chat, but I will go ahead and ask it and so you can answer it out loud. But someone had asked, we have several patients who cannot receive blood transfusions due to religious reasons. Can University of Missouri do bloodless transplant?
Unfortunately, we do not. We have actually discussed this issue previously when we did have a patient in a similar situation. When you're performing surgery, we have to assume that there would be bleeding. Sometimes it can be bad enough that it would require a transfusion. So our surgeons do not feel comfortable, going in and, maybe having a problem with bleeding and not being able to use a transfusion to save the patient's life. So we decided that's something that our program would not be willing to do, and we suggested that the patient look at other programs potentially. I believe there may be very few programs that might be able to handle those situations. I don't know exactly the programs that are doing that, but we heard that there may be some, but unfortunately I do not know which programs are doing that.
Okay, thank you, Dr. Yera. So another question, if a patient is temporarily inactive due to health status, but finds a living donor match, would the patient need to improve their health status before receiving a transplant?
That's Mary Beth. And yes, they would, but a lot of it depends on what's going on with the recipient. Generally, we say if they are improving and we expect them to recover from whatever they have going on, then yes, then they should go ahead and refer their living donors. And I kind of hate to say it, but if it's a compliance issue, if you have a living donor who wants to give to somebody, it's like dangling a carrot before a horse. You can tell them, you need to fix this about your compliance because I have this donor who wants to give to you. Now, if the recipient is sick, legitimately sick, and we know they're going to recover, yes, go ahead and refer. If they're not going to recover so much, like I said, it depends on the recipient. My advice is just tell them to refer their living donors, regardless of what's going on with the recipient. And we can sort that out. They certainly, they don't have to figure that out at the dialysis unit.
Okay, thank you. And anyone, if you have questions, please put them in the questions pane or the chat pane, and we will get to those. Dr. Urim, you had mentioned the high donor hospitals when you were talking about multi-listing and how the donors or how the kidneys are allocated. How would you know what hospitals are high donor hospitals?
So, sorry, go ahead.
Oh, I was just saying if there was a way to know that, or if it may be just kind of assumed if it's, a large city serving a larger population.
The organ procurement organizations, those, that information is public, I believe. The CMS has ratings of organ procurement organizations, and they are required to reach certain benchmarks. So that information is public. So the donor hospitals kind of feed into that organ procurement organization. So in general, if your organ procurement organization is high performing, meaning they are able to procure organs very efficiently and able to get those transplanted, then typically the hospitals that are feeding into that organ procurement organizations are supposed to be high performing as well. So I guess you could kind of extrapolate from those, but certainly I think knowing how well your organ procurement organization is doing is going to help extrapolate that to the donor hospitals that serve that OPO. In terms of the multi-listing, it would help because let's say we have a donor available at University of Missouri, and if a patient is listed at University of Missouri but is also listed at St. Louis, since we are still within that 250 nautical mile radius, the patient will show up on both those lists possibly. But because the donor is at the University of Missouri Hospital, the patient being listed at the University of Missouri program will get extra points called the proximity points, because the donor is actually here and the recipient is also listed here. So in that sense, it would help multi-listing. So if the patient is listed at St. Louis University and they have the donor right there, then the patient will have more points and will show up higher on their list. So in that sense, I think it helps for patients to multi-list. But if they are in an area where their organ procurement organization is not doing very well, then there is not much they can do about it. For example, I think there are certain OPOs in the New York area that were so poorly performing that they were really cited by CMS. So there is not a whole lot you can do about that. But in terms of just knowing what your OPO is doing can help get that information. I don't know if that makes it any clearer, but.
Yep, thank you. And I think you all have one of your financial folks on the line, but hopefully somebody can answer this. So who is it that they work with to, if they only have Medicare and their Medicare runs out after 3 years, who should they work with to get some sort of supplemental insurance, or do you make sure that they have a supplemental plan prior to transplant? Because I recently had a patient call the network and basically, and I'm sure that there were probably some other indicators, but the issue was they went to pick up their transplant medications and they said that they couldn't fill them because their Medicare had run out. So there probably were indicators prior to that visit to the pharmacy, but I'm just curious, is it the transplant social worker they should be working with in that, or someone at the transplant facility that can assist them with that?
This is Sydney, the social worker. So we discuss Medicare running out usually at the first clinic evaluation. And if someone only has Medicare, I will talk to them about a supplement that day, because Medicare A and B will only cover 80% of the transplant and 80% of the immunosuppressives. So only having Medicare A and B is not, I would be concerned that that would incur a pretty large cost for the patient before they even get to that 3-year mark where their Medicare will run out. I also monitor who is approaching that 3-year mark and check to see who has a secondary insurance, who has a plan. A lot of our patients will reach age 65 before that 3-year mark, and it would automatically roll over into having senior citizen Medicare. So I guess to answer your question directly, I try not to ever let it get to that point. It's also the same with Medicaid. A lot of times, if a patient only has Medicaid as insurance, the next year after transplant, when they are reevaluated, they may no longer be considered disabled because they're not on dialysis anymore. They're able to return to work, and they might not qualify for Medicaid. So I do tend to talk to patients in advance, once again, even at their evaluation appointment, and say, this is something that needs to be planned for. Start looking for jobs once you're able after transplant, or marketplace insurance, things like that. And once again, going back to us having a smaller program, I'm able to keep a close eye on our post-transplant patients and know who's coming up and might be losing their insurance.
Okay, great. That's helpful because I'm never sure if we are referring back to the transplant center or dialysis center. So here is another.
When in doubt, just give me a call and I can at least get you to the right person.
Okay, great. Here's another question from a participant. What is available for illegal immigrants? How much would it cost without insurance, and is there any assistance available?
Stephanie, do you want to jump in now?
That goes through the accounting department. That's not something that we handle up front. We go to the accounting department, they come up with a figure, and then we talk to the potential recipient about it and see if they can afford it.
But no, there are no assistance programs, unfortunately.
Okay, thank you.
Just to kind of add to that, this is Beth again. We, for whatever reason, and I guess it's just because of where our centers are, we do get a number of Mennonite and Amish patients, and they don't have insurance. So if you have those particular people in your dialysis units, they do go through that process where we quote them a price. But they live in very, tight-knit communities run by elders, and more times than not, they will go to the elders with that, and the community pays for their transplant. And also, it's kind of nice because they also usually always come with their own living donors. So if you have some of those patients in your dialysis units, transplants are negotiable with the university. Stephanie Sapp, who's our financial coordinator, assists with that along with our finance department coming up with a price. Once that's set, then we kind of proceed with their living donors. Usually they almost always come with a living donor. So I hope you find that helpful.
Okay. How do dialysis facilities know if their patient is listed or not?
It's Mary Beth again. So dialysis facilities are copied on all the letters that are sent to the patient, and also the patient's physician is copied on all the letters that are sent out. And letters are sent out when patients are put on the list, when they're made active, and when they're made inactive on the list. And I think currently right now, because we kind of go back and forth as to how this should best be done, we were mailing letters to the centers. But then we were told they weren't getting the letters. So then we decided email was a better option. So right now, and I'm going to have Stephanie correct me if I'm wrong, we are emailing letters to the center's social workers. Am I correct on that?
Yes, I email a copy to whoever the social worker is. I have a list of all of the dialysis units and the social worker that's assigned to the unit.
Okay, thank you. So if someone is listed elsewhere and they want to list with your facility, do they still need to go through your evaluation process?
This is Chelsea, pre-transplant nurse coordinator. So if they're listed at another facility, we still want them to come and meet us in clinic. But as far as all of the testing goes, if they have current testing with the other facility, that's current within a year, we usually work with the other centers and just request that. And if we need anything additional, then we bring the patient back in for testing.
Okay. And the smartphone app for living donation that you had mentioned earlier, is that something that is, I know it's a project that you all are working on, but is that something that's available to the general public yet? Or is that just for specific people working in that project?
Right now, it's part of the research study. It is not available to the general public. But I think there are about 10 to 12 transplant centers in the United States who are participating in this research project right now. And so we are one of them. So you have to have a center that is participating in it. So if you come to us and we put you on the list, we will offer this to you. You have to consent to use it and to send some information back to Johns Hopkins. So that's the donor app. But I also have, lots of patients. We have lots of patients looking for a kidney. Prior to us signing up for that donor app study, that have Facebook pages dedicated specifically to telling their story and looking for a kidney. So and there's more than one way to do it other than just using the donor app.
Okay. There was another question. How do we ensure that the coordinators have the correct social worker information, since that changes that can change often. Is that something that the patient tells you who their social worker is, or how do you keep track of that?
No, Kathy Ashbell has, this is Stephanie, the financial coordinator. Kathy Ashbell has been getting a list from, I'm not sure who.
It's
And
from Missouri Kidney Program.
I know it's been updated twice now in the last year, I believe. But that's where I get my information from, that list.
Okay, thank you. And I know you all mentioned COVID a little bit with telemedicine, but how have your processes changed, or is there something that patients should know kind of in the midst of all this COVID-19 going on, as far as you all taking referrals or living donor transplants? How has that affected your program?
So it's Mary Beth again. The program, we kind of put the living donor program on hold, which I believe the majority of transplant centers did do that for a while. But we are kind of back up and running now, and I believe we're going to be doing one in July. Our hospital right now is still on a kind of a lockdown protocol where patients who are testing come in, but they cannot bring anyone with them. You know, they reevaluate that every week. I think the next step will be allowing patients to bring someone in, one person in with them, but right now it's just the patient. So our recipients are coming in for testing again. We had to do a bunch of rescheduling, so there wasn't much going on during April because of COVID. But we have patients coming in for testing in order to go on the list. We are not doing COVID testing on them. As far as living donors go, they are definitely going to be COVID tested probably twice prior to surgery, and so will the recipient. As far as kidney offers go for deceased donors, a deceased donor offer that comes in for somebody, those donors are managed through Midwest Transplant Network, and they are all COVID tested. So when those offers come out, we know whether or not they were COVID positive or COVID negative. And the recipients, when they come in for a transplant, are COVID tested prior to transplant.
Okay. So we've heard that some centers require, I mean, I know you just said the hospital is not allowing people, but do you require a care partner before someone that's dedicated to that person and getting them to appointments, or, you know, to and from the hospital? Do you require that to have somebody listed?
I can speak to that. This is Sydney, the social worker. What I tell patients in their pre-transplant evaluation appointment is that after surgery, they will be in the hospital for 7 to 10 days. And after that, when they go home, we would like them to have someone that can stay with them 24 hours a day for the first week. That's kind of the bare minimum that we look for. It is also very beneficial to have someone there in the hospital. Kathy goes over all of the medication setup before the recipient is discharged, and it is a lot to take in, especially a few days after surgery. So it's really helpful if someone can be there to, you know, be another set of eyes and learn how to do the medications. Also, after transplant, the recipient won't be able to drive for several weeks, so they will need someone that can drive with them. Beyond that, it is good to have a support person or more than one support person to come to as many appointments as possible. And it's important to remember that when we see a patient for the first time for their evaluation, that could be several years before they're actually transplanted, and things come up. Maybe if they have one care partner designated to take care of them, that person could get sick or move or no longer be available for some reason. So it is important for recipients to plan for multiple support persons to help them out after surgery and start asking people for rides to clinic appointments. And if the patient doesn't drive, they need to think about who could drive them to the hospital in the middle of the night if we were to call them for a kidney offering.
Okay, great, thank you. And I think going back real quick to the ensuring that you all have the right information for the social workers, I would encourage any dialysis center staff that is on the line or listening to this that if you are new to a clinic or you've changed clinics or there's been some sort of a change, I would definitely reach out to any of the transplant centers that your patients are listed with and let them know what that change is so they can update that patient's records. That way that helps them out in trying to keep track of where everybody is. But you might just put that on your to-do list for the next couple weeks and reach out to those transplant centers and make sure that they have your contact information in case they do need to send you information regarding that patient status on the wait list. And here is their contact information with a phone number and a fax number. I don't think that there are any more questions. Did you have any more slides, Chelsea? Is that the last one?
Yes, this was the last one.
Okay.
Debbie, this is Preeti Uram, nephrology. So I do want to say a few words, though. So when we are doing transplants, besides the patients themselves, obviously, they are a big part of the transplant process. They are very important in the process. But the dialysis center and dialysis staff are a really big part of this process as well. And they're probably the second most important partner in this process. And we do rely on them provide us, information about the transplant and also help with the evaluation. And they can also provide a lot of support for the patient because of the relationship they have with the patient, supporting them through the process. Sometimes it can be lengthy. So I think it's very useful for the social worker and the dialysis staff to be involved and kind of help the patient along the way, and kind of be a liaison between the transplant center and the patient. So we do really appreciate working with our dialysis units and do value their the partnership, and hope to help you in whichever way we can.
Thank you, Dr. Uram, and thank you all for an excellent presentation. As a reminder, there is a short survey that you will be able to take after this presentation. And don't forget about the handouts that were attached. They are the contraindications list, the referral list, and the My Transplant workbook. If you have any questions, please reach out to us, and our contact information is provided on the slides. We have Network 10 and Network 12. So I think this will conclude our presentation for the day. We appreciate all of you joining us. And again, please take a minute to fill out that evaluation and have a great day. Thanks, everybody.
Thank you, Debbie.
Thank you.
Thank you.
Thank you.